Before I start, I'm going to show where I'm from. I'm from central part of Japan, wonder north of Tokyo, but this picture does not look like Japan, I guess. My hospital is one of the university-affiliated hospital with a busy trauma service. And adjacent to the university hospital, we have a 4-storied center for maternal fetal medicine. This is the only tertiary perinatal center in the prefecture of the almost 7 million population. So we get a lot of high-risk referral on perinatal medicine. Now I'm going to talk on the post-cesarean analgesia to maximize safety and minimize side effects. When you give analgesic after cesarean section, we have to think about certain unique challenges for post-cesarean patients. For example, the mothers need to take care of their babies starting soon after birth. They have to ambulate early to prevent venous thromboembolism due to pregnancy-related hypercoagulable state. Also, they want to avoid depressant effect of analgesic agents on breastfed infant. Also, nature of post-cesarean patient pain is unique. It's both somatic and both visceral. So post-cesarean analgesia requires safe, effective pain relief with few maternal and neonatal side effects. Also, we want to have a minimum motor or sympathetic blockade for early ambulation when you are using a neuroaxial analgesic technique. So these are probably the most frequently used methods of post-cesarean analgesia. In Japan, I think intermittent opioid supplemented with NSAID suppository will be the mainstay in most of the institutions in Japan, followed by continuous epidural infusion, and intrathecal morphine is not very frequently used. But however, when you look at the ASA guidelines, for practice guidelines for obstetric anesthesia that was updated in 2007, it says that for postoperative analgesia after neuroaxial anesthesia for cesarean delivery, neuroaxial opioids are preferred over intermittent injections of parenteral opioids. They also acknowledge that the literature is insufficient to evaluate the impact of epidural opioids compared with intravenous PCA. In addition, the literature is insufficient to evaluate spinal opioids compared with parenteral opioids. But, however, anybody who uses the intrathecal morphine must have been convinced with the excellent analgesia of prolonged duration. Interestingly, first use of intrathecal morphine was reported in Japan almost 120 years ago, 1902. Dr. Kitagawa studied medicine in Germany under Dr. August Beer, and he gave spinal anesthesia for Japanese patients, in 6 patients. And interestingly, 2 of them was given intrathecal morphine, 10 or 20 milligrams for a variety of pain conditions such as post-herpetic neuralgia. I'm glad that they did not develop respiratory depression and not die. He reported this finding as a letter to the editor in Anesthesiology Journal, saying that nothing new under the sun, because only 70 years later, Dr. Tony Yakshi found the spinal cord opioid receptor after the first use by Dr. Kitagawa. So our current practice is to give spinal hyperbaric bupivacaine 12 milligrams, rather larger amount as Dr. Ganki explained. We try to avoid the ineffective cases. We also give intrathecal morphine 0.15 milligram as well as intrathecal fentanyl, 10 micrograms. And the patient may need supplemental NSAID, loxaprofen, which does not go to the breast milk very much amount. And also we mandate monitoring of continuous SpO2 and recording of SpO2 and respiratory rate every 1 hour for 24 hours. So our nurses have been very, very cooperative. Thanks to the intrathecal fentanyl, patients complain minimum discomfort during uterine externalization or peritoneal closure. So we try to start breastfeeding in the oral. This is in accordance with the WHO and UNICEF guideline to encourage breastfeeding. And also, thanks to the intrathecal morphine, patient can ambulate 4 hours after surgery. Usually, our surgeon takes longer, about 1 hour for surgery. So, after spinal stick, in 6 hours, intrathecal bupivacaine wears off. This is when we encourage early ambulation as our routine. And this is partly made possible due to the 27-gauge pencil point needle, which has a PDPH incidence of 0.01% in my institute. But when you're using intrathecal morphine, you must be worried about the delayed respiratory depression. Has anybody experienced a patient of delayed respiratory depression after cesarean section? Raise your hand, anybody? Okay, only one. And you and me are the only two, I guess. So this is a very rare complication, but there is. This is due to the low octanol water partition coefficient. Less lipid-soluble morphine migrates inside the CSF up to the brainstem 8 to 12 hours later. I was once called in to see the patient who had continued to have SpO2 alarm beep by the nurse. So I came to see the patient and I hooked up this mainstream type capnograph with nasal and oral sampling port, which is manufactured by Nihon Kohden Company. And this is a recording of this monitor. As you see on the black lines, the patient gradually decreased her respiratory rate down to 0, followed by green line of endothelial CO2, which abruptly decreased to 0. And only afterwards, SpO2 on the blue line decreased down to 79%. So that desaturation is actually a late sign, but it is not practical. It is not practical to monitor endothelial CO2 in every post-surgical patient. So this is why we go by the SpO2 monitor. This is a continuous recording of this particular patient. On the upper panel, you see the SpO2 decrease repeatedly, and on the bottom column, you see the respiratory rate goes down to 0 on a repeated basis. And at this point, we gave a naloxone, and here we started an oxygen administration. So after this case, I saw that we have to look at the true incidence of delayed respiratory depression after intrathecal morphine. So we studied 1,900 consecutive patients in our institution over 7 years from 2000 to 2006. 2000 was the year when I moved into my hospital. So I collected these patients myself. These are the summary of our 6 cases who developed this respiratory rate less than 10 per minute. It all occurred between 1 hour to 13 hours. But this particular patient, number 5, had a BMI of 34.7 beforehand, and she was found to have repeated desaturation 4 consecutive nights after cesarean section. So apparently she had obstructive sleep apnea. So I think we have experienced 5 patients of delayed respiratory depression, and only 1 patient which required naloxone. So the incidence of severe respiratory depression, delayed respiratory depression after intrathecal morphine, turns out to be 0.052%. It's rare, but it's still there. In the subgroup analysis that we did up to 2003, we had 5 and 5 patients, and we had a very large number of mild desaturations. The 49 patients had SpO2 below 95%, and I looked up the possible cause of desaturation, such as preeclampsia, pulmonary edema, multiple gestation, infection, and so on and so on. But in 16 patients, I could not find any causes that can cause desaturation. So the incidence of mild desaturation was 3.2% after intrathecal morphine. This is the reason why we mandate SpO2 monitoring for the 24 hours after intrathecal morphine. Contrary to that, practice guidelines from ASA for the prevention and the detection of respiratory depression states that monitoring should be performed for a minimum of 24 hours after administration. By monitoring, they mean that watching the patient's condition, mental status, respiratory rate, respiratory pattern, not SpO2. They also continue to say that monitoring should be performed at least once per hour for the first 12 hours after administration, followed by monitoring at least once every 2 hours for the next 12 hours. So after 24 hours, frequency of monitoring should be dictated by the patient's overall clinical condition and concurrent medication. So if you're taking care of a otherwise healthy postpartum patient, maybe we can stop monitoring at 24-hour post-op. I asked the reason why they did not incorporate pulse oximetry as monitoring to one of the task force member, Dr. Craig Palmer. He says that due to the lack of central monitoring capability of currently commonly used pulse oximetry, the panel did not think that it is feasible or practical. Now I move on to the continuous epidural infusion as a post-cesarean analgesia. Our current regimen is 0.2% rather concentrated amount with 4 mg per ml of fentanyl at the rate of 4 ml per hour through the low thoracic catheter. We use this technique when patient had extensive surgeries such as cesarean hysterectomy. I want to introduce a very interesting study that was published in A&A 1996 from Kyoto in Japan. They place a low thoracic catheter and they give a bupivacaine top-up followed by continuous infusion, fairly low amount, 0.25% bupivacaine at the rate of 0.7 ml per hour for 3 days, and they supplemented with the diclofenac. It was their routine to measure the baby's weight after every breastfeeding, so they could total the weight of milk fed by the breast, the breast milk injection, depending on the day. And as you can see on the open circle, continuous infusion bupivacaine baby had a better, larger amount of milk ingestion, resulting in a larger amount of weight gain up to 11 days post-op. It was their routine at that time to keep the patient 11 days post-op after cesarean section. But by giving a continuous epidural infusion and good pain relief, probably with blockade of sympathetic reflex, maybe we can increase the breast milk production and also we can increase the oxytocin production. Then you can have a chubby, nice baby like this picture. But they could not repeat this, their study when they incorporated buprenorphine on top of the bupivacaine for continuous epidural infusion. The reason they speculate was that buprenorphine crossed over to the breast milk and affected the breastfeeding behavior of the infant. So we really need to look at the baby's behavior and breast milk excretion of analgesic agents that we give. The upper panel shows the study from Greece. They looked at the breast milk excretion of ropivacaine, and the result was recently published in Regional Anesthesia and Pain Medicine. The milk plasma ratio of ropivacaine was 0.25 at 18 hours post-op and 0.23 at 24 hours post-op. They were quite low compared to the previously reported milk plasma ratio of lidocaine, 0.83, and that of bupivacaine, 0.37. So ropivacaine may be the agent to use for post-operative continuous epidural infusion after cesarean section. How about fentanyl? The study from Saudi Arabia, they studied patients with epidural anesthesia followed by continuous epidural infusion of fentanyl, 20 micrograms per hour, but they don't tell how long. And they also gave a spinal anesthesia on other group, followed by fentanyl IV, and they say they doesn't report the total amount of fentanyl. But however, the colostrum concentration of fentanyl was 0.40 nanogram per ml at the epidural group, and 0.19 nanogram per ml in the IV fentanyl group. And at the 24 hours, the concentration of fentanyl are both very negligible in both groups. So they think that, and I think that fentanyl seems to be probably okay on the breastfeeding mothers or nursing mothers. And also the Saudi group found that the breastfeeding behavior were not different between these two epidural fentanyl group, epidural and IV fentanyl group. So now I move on to the IBPCA, another frequently used method after cesarean section. The Cochrane systematic review was published in 2006 by a Boston group, Dr. Dankar. He was also one of the mentors at MGH. They looked at the 10-year span of 55 studies, and the patients were about 2,000 in each arm. The result was that the BAS was lower, about 10 millimeter in IBPCA. By the way, this is the post-surgical patients, not necessarily a post-cesarean patient. And the satisfaction was better with a slight amount, but statistically significant in IBPCA. However, morphine consumption was larger in IBPCA, and also higher incidence of pluralitis was noted. So IBPCA is effective in post-surgical patients, but the question is, which agent to give? So Dr. Viteros studied neural behavior after meperidine IBPCA and compared to morphine. It was a preliminary study of 5 patients each, and they measured that the breast milk concentration of these analgesic agents also metabolized like morphine 6-glucuronide and normeperidine. And they found that meperidine accumulated in the breast milk more than the morphine. And also they examined the baby by Brazelton's neonatal behavioral assessment scale, NBAS. And this is their result, NBAS score on the 3rd day of life. They studied the 4 items of Brazelton's NBAS, alertness and orientation to human face and voice. The reason why they only studied this part of the Brazelton study exam was that they wanted to avoid type 1 error by doing many studies on one study. And the results are shown in the numbers here. The low numbers indicate the inattentive, so which is bad. And the high number 9, is the maximum, always alert in best periods. So as you can see, morphine baby did better than meperidine baby in all these items. I was shocked by this study because meperidine IBPCA was a routine when I was a fellow at the Brigham and Women's in 1992. The same researcher did a follow-up study in 100 patients. They give epidural morphine followed by IBPCA, either with morphine or meperidine. And they had bottle-fed infants as a control for neural behavior. Sorry for the busy slide, but please just focus on this alertness on the upper panel. And the upper bar is the bottle-fed control babies. And this is meperidine, and the bottom is the morphine sulfate IBPCA group. The gray bar is the NBAS low, which is good, which is bad. And the NBAS 7 to 9 is the black bar, which is good. So just look at the black colors. Good news is that the meperidine did the same as the bottle-fed infants. But however, morphine babies did consistently better in alertness and orientation, and I'm not sure why. This is on the 3rd day of life. On the 4th day of life, morphine and meperidine, when morphine and meperidine were compared, again, morphine did better and meperidine did worse. But morphine did not do better compared to the bottle-fed infant. So when you're using IBPCA, morphine is the drug of choice. Finally, I want to mention the future possibility of post-cesarean analgesia briefly. It has been shown that preoperative anxiety, pain sensitivity, and patient expectation are associated post-operative analgesia, not necessarily cesarean. So if we could repeat this study in a post-cesarean patient, maybe we can adjust the IBPCA setting or the amount of intracerebral morphine depending on these preoperative predictors. And also, tailor-made post-cesarean analgesia may be approaching in the near future. This is a famous study by Alex Caesar at KKM in Singapore. He is also the co-president of OASAO that was published in 2008. Single nucleotide polymorphism, SNP, of human mu-opioid receptor gene influence patient pain perception and patient-controlled intravenous morphine consumption after intrathecal morphine for post-cesarean analgesia. Look at the left panel. This was the morphine consumption, and AA wild type has the least morphine consumption. And AA wild type complains less pain post-op. So if you are taking care of the patient who might have a SNP in this morphine receptor gene, they may need more analgesic agents. So in the near future, we may have to tailor your post-operative analgesic regimen depending on the patient's ethnicity that you're taking care of, or maybe the SNP of the patient. So to summarize, intrathecal morphine provides excellent prolonged analgesia and enables early ambulation with negligible effect on the breastfed infant. However, delayed respiratory depression is a clear and present danger, although very rare, requiring monitoring for an extended period of time with pulse oximetry, in my opinion. epidural infusion with ropivacaine and fentanyl seems acceptable for breastfed infants. And also morphine IVP-CA is acceptable on this regard. Even though I didn't mention, NSAID is a good agent to alleviate uterine contraction pain, so this is a good supplementary agent. So I'd like to thank you for your kind attention, and also would like to thank you, the people in India and from all over the world, who provided generous and kind support after earthquake and tsunami happened 6 months ago. This is a picture of my hometown. And in Japan, we have a saying that winter is always followed by spring. So I hope we have a good spring next year. And thank you very much for your kind attention indeed.